You know that knowing your cholesterol is important if you want to prevent catastrophic health crises like heart attack and stroke. But there's so much contradictory information like women with higher total cholesterol actually live longer. No, wait, LDL cholesterol is a death sentence. No, wait, actually it's low HDL that'll kill you. Hang on, it's all about triglycerides. And even major studies have contradictory results. So what does a forward-thinking woman like you need to know to be able to put more years lived in good health into her future? Today's episode is a great place to start. You're listening to the Health Courage Collective podcast, episode 171. Smart women know this about cholesterol. Welcome to the Health Courage Collective podcast, the show for women who are too busy to slog through hours of generalized, inapplicable, and often contradictory health information, but too smart to ignore that a few minutes of focused attention now can prevent years of suffering in the future. I'm your host, Christina Hackett, a pharmacist who doesn't want you to live on prescriptions, a certified coach specifically trained to maximize your potential, and a compulsive learner obsessed with preventative, cutting-edge, holistic, and integrative medicine. I'm on a mission to increase your physical and mental resilience so you can fearlessly look forward to your next 40-plus limitless years. Your time is now. Let's go. Hello, my friend. I'm so happy that you are here today. How is your call to adventure? Have you gotten a new call to adventure in the past week? It might come in the form of an annoyance, but that's your chance to step up and live your values and become the hero of your own story. Today, we're going to talk about something completely foundational to longevity, bread and butter basics, but unfortunately, most people, including physicians, don't understand it well enough to help you age at an elite level. So, like a lot of things, you have to educate yourself well enough to know whether you're getting elite level preventative care or not. I think, luckily, modern medicine is awesome at emergent care and disease treatment, but for prevention, you need to show up to the party prepared in most cases. So, let's get you there. I'm hoping you know the statistically most likely thing to kill you because that gives you power right there. More than cancer or accidents or flesh-eating bacteria or getting eaten by a dingo, the most common cause of death in both men and women is atherosclerotic cardiovascular disease. This is when plaque builds up in the walls of the arteries, usually the coronary arteries, but also sometimes in the carotid or cerebral arteries. I'm sure you know that you don't want plaque blocking off your blood supply. Lots of things can damage the lining of your blood vessels, called your endothelium. The more you can prevent all of that from happening, the better off you are. We'll talk more about your endothelium in the future, but today we're going to focus on cholesterol because I think people know that they don't want bad cholesterol. Spoiler alert. There's no such thing, but they don't fully appreciate how cholesterol works and how that affects their chances of dropping dead today or 30 years from now. So, cholesterol is good. Without it, we would not exist. We would not have cells with membranes, which would be game over. We also wouldn't have any hormones. It's absolutely essential for cell membranes and to produce hormones and bile acids. It also helps in the synthesis of vitamins. I was trying to think of a good analogy, and this is the first thing that came to mind, but there's got to be something better, but I can't think of what it would be. One of you probably has a much better idea. I wish you could tell me. But let's say cholesterol is like bees. We know from the Bee Movie with Jerry Seinfeld, which I love, that the world would shrivel up and die without bees. Because bees are awesome. We love bees. My boys used to call them fuzzy buzzies when they were little, and I wouldn't put it past them to call them that now, just with a lower voice. But a swarm of bees inside your house would not be awesome. No matter how good you know they are, we don't want them congregating where we live. You can imagine the cascade of events if you started having several, then several hundred, and several thousand bees inside your house. Similarly, the only bad outcome related to cholesterol is when it sets up shop inside the wall of an artery, because it doesn't belong there. And if it gets in, it tends to set off a cascade of emergency calls for help, called inflammation, that is a protective response that can go overboard. Again, this is the only case where cholesterol is bad, because it's where it doesn't belong. So, measuring total cholesterol in the blood doesn't really tell us anything about our risk of premature death. I think one of the best places to learn more about this topic is from Dr. Peter Attia. He goes way more in depth, and I highly recommend him if you do want to dive deeper. A quote from him is, "Eating cholesterol has very little impact on the cholesterol levels in your body. This is a fact, not my opinion. Anyone who tells you different is, at best, ignorant of this topic." End quote. He can explain to you very well why this is. Esterified versus unesterified cholesterol and how the gut preferentially absorbs unesterified cholesterol from bile acids that have been effluxed from the liver, etc., etc. It's important, but we won't take the time to dive into all of that today. Refer to him if you want to know more. So before we make the next crucial point, let's just review. Cholesterol is always good. Total cholesterol level doesn't tell us anything about whether we have cholesterol where it can potentially cause harm or not. And eating cholesterol has almost no effect on your cholesterol level. Next, essential thing to know is cholesterol can't just exist in your bloodstream. Cholesterol is not water soluble, so the only way for cholesterol molecules to travel in your bloodstream is to get on a boat. Now we've got bees buying tickets for sea voyages. This is getting a little weird, but the only way for cholesterol to get around our body, which we want it to be able to do, is via carrier proteins. Carrier proteins are the boats that make it possible for hydrophobic cholesterol to travel in blood plasma. Carrier proteins bound to lipids are called apolipoproteins. There are different types of apolipoproteins that matter to our health. One is called apolipoprotein B or ApoB, and almost all of that is found on low-density lipoproteins, abbreviated LDL. Most apolipoprotein AI or ApoAI is found on high-density lipoprotein, abbreviated HDL. All cholesterol is the same. It's just cholesterol. There isn't good cholesterol and bad cholesterol. The LDL and HDL that you've heard of before aren't different types of cholesterol. They're different kinds of boats, kinds of carrier proteins that have the ability to transport cholesterol around. There are also chylomicrons found in the intestine and VLDLs from the liver that transport triglycerides around. Actually, most of the cholesterol you need and use can be manufactured by the cell that needs it. So cholesterol delivery isn't needed by most cells in the body. For those that do need it, the LDL boats are the main cholesterol delivery apolipoproteins, which transport a lot of cholesterol back to the liver. This is a good thing. Unfortunately, under certain circumstances, LDL transporters can penetrate an artery wall and deliver its cholesterol load there. This is what kills us. Imagine a nice boat sailing into your bedroom and opening up to let out a huge swarm of killer bees. Not good. LDL, while it's nicknamed bad cholesterol, actually helps with a lot of physiologic cleanup, taking cholesterol safely back to the liver. So not all LDL particles are bad, but sometimes they are directed to go dump their cholesterol in an artery wall, and that's not good. You're probably familiar with a typical cholesterol panel blood test report. It will usually report total cholesterol, serum triglycerides, HDL, LDL, and sometimes non-HDL cholesterol. We're told that we want low total cholesterol, low LDL, and high HDL because we're told that LDL is bad cholesterol and HDL is good cholesterol. The only problem is that those numbers don't really correlate with your longevity or your chance of dropping dead in the next few days or months or years or decades. I've heard that in a lot of cases, especially in women, survival rates are higher among women with higher total cholesterol numbers. So it makes it a mess to try to understand what we need to do. If it doesn't give us any reliable data, why is it that we measure all this stuff? Well, part of it is that our understanding has been getting better and better over the last few years, and part of it is because it's actually a lot easier to count up the total number of bees on a certain kind of boat. The total number of cholesterol particles on board an LDL or HDL boat is easier to measure than the number of boats in the river. Until recently, we didn't have the ability to count the number of apolipoprotein particles, but we can now. In a typical blood test, LDL cholesterol, the one we're told is bad and important, is calculated with a math formula. It's not directly measured. And the total number of cholesterol particles traveling in LDL boats doesn't really matter anyway. What matters is the number of low-density or LDL boats in the fleet. If you want to put more years lived in good health in your future and prevent or drastically delay the most common cause of death, you'll need to hear about something called ApoB. ApoB is a protein on LDL, VLDL, and IDL particles. All of the particles with ApoB are the particles, or boats in our analogy, that have the ability to deliver their cholesterol cargo into an artery wall. 90 to 95% of ApoB particles are LDL particles. So ApoB is kind of essentially a count of how many LDL boats are in the river. The main driver for cholesterol being deposited in the artery walls is the number of LDL boats, or ApoB particles as a proxy measure, in the bloodstream. How many boats at a time and for how many years that boat concentration is high. When there are a lot of boats sailing around for a long time, the chances of one of them depositing its payload of cholesterol into an artery wall goes way up. There's more to this, something else that causes the boat to pause there, like an unhealthy or inflamed artery wall lining. But it has been proven to be the case that the more ApoB particles or LDL particles there are, the more likely they are to deposit cholesterol into the artery wall. And not to be a broken record, but the number of LDL particles is not what's reported on a standard lipid panel. What's reported on a standard panel is the total amount of cholesterol being carried around by LDL particles. It's different, and it's not even directly measured. It's calculated with a formula. Okay, if all of these acronym names are making you crazy, plug your ears and go, na 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 na, for a few seconds. But something that confused me for a while was the difference between ApoB, LDL-C, LDL-P, and something else called Lp(a). ApoB is the number of particles that have the potential to deposit cholesterol in artery walls. 90 to 95% of these potentially atherogenic particles are LDL particles. LDL-C is the total amount of cholesterol carried by LDL particles. That's what you get on your standard lipid panel report. And it doesn't tell you anything too useful. LDL-P is the total number of LDL particles. This is the thing we want to know. It's pretty similar to the ApoB number. Both are invaluable to know, and both are the thing that we care about, either ApoB or LDL-P. Just regular LDL or LDL-C doesn't tell us what we need to know. Then there's Lp(a). That's a special kind of LDL particle. It's an extra bad LDL boat. I'm not a boater or a water sports person at all, but I've heard from people around me that you can't launch your boat in lakes in Utah if you're coming from out of state or if you've been to a lake here called Lake Powell until you've completed some kind of decontamination procedure to show that your boat is free of quagga and zebra barnacles. Boats with these barnacles can spread mussels to the lakes they enter, which can cause tremendous problems for the lakes that they sail in. Lakes with quagga and zebra barnacles introduced to them see an explosive growth of bottom algae and weeds. The entire food chain of the lake gets disrupted all the way up to the biggest and best fish that live there. They can clog pipes big time, so municipal water, agricultural irrigation, and power plants can all become non-operational. Any equipment in the lake, like motors and docks, can be ruined. Beaches can become polluted and nasty and dangerous. It can really be devastating for a lake to become infested. Sadly, it's hard to prevent because the barnacles can survive out of the water for 30 days and they're small enough to be missed by a standard visual inspection. The analogy isn't quite perfect, but we'll call Lp(a) barnacle boats. Lp(a) is still a type of boat, a protein carrier for cholesterol. It's a special subtype of LDL. An extra dangerous type of LDL because it's stickier than other LDL particles and is much more likely to cause death and near death. To the best of our knowledge, Lp(a) levels are mostly determined by genetics. So it's a crucially important thing to know and most likely not one that you can affect by lifestyle choices. And it's not reported on a typical standard lipid panel. Here's another quote from Dr. Peter Attia. If you were only, quote, allowed to know one metric to understand your risk of heart disease, it would be the number of ApoB particles, 90 to 95% of which are LDL particles, in your plasma. In practicality, there are two ways to do this. 1, directly measure ApoB in your plasma, or 2, directly measure the number of particles of LDL in your plasma. If the number is high, you are at risk for atherosclerosis. Everything else is secondary." End quote. So there are a few tests that can directly measure ApoB particles, and one test called the NMR lipo profile that can directly measure particle number of LDL. The NMR test can also tell you particle sizes, which will tell you before any other lab test whether you're becoming less sensitive to insulin. Before your insulin levels or glucose levels start to show any signs of resistance. So that's pretty cool to know too, and the earlier the better. Whew, look how smart you are. Now you know that LDL cholesterol isn't bad cholesterol. It isn't even cholesterol at all. LDL is a protein carrier for cholesterol, and all cholesterol is good. And that a standard lipid profile isn't going to tell you the only thing you really need to know, which is how many LDL particles or how many ApoB particles are sailing around in your plasma. So what about good cholesterol? Haha! All cholesterol is good cholesterol. You may have heard that HDL is good cholesterol, and increasing your HDL lowers your risk of heart attack and stroke. Now you know that high-density lipoproteins are not cholesterol. They are protein carriers for cholesterol. They're a different kind of boat, one that can't dock inside an artery wall and deposit its cholesterol there. This is a fascinating topic I thoroughly enjoyed learning about, but I'm going to keep it brief for you today because I assume you're not as weird as I am about this stuff. If you are, go read about the progress of trials on Pfizer's drug torcetrapib. While it seemed like people with high HDL levels seemed to have lower incidence of coronary artery disease, and HDL was found to carry cholesterol out of the artery walls and back to the liver, which is excellent, just raising total levels of HDL, or the HDL-C number, which is a measure of total cholesterol carried by HDL boats, helped no one. HDL-C is what is reported on standard lipid profile, and it tells you next to nothing. It's the total number of cholesterol molecules carried by that type of boat. It doesn't matter. Just like with LDL carriers, what matters is not the total amount of cholesterol transported by HDL particles, but how many individual particles you have sailing in your plasma. As your HDL-C level rises above 45, it's not because you have more HDL particles. It's probably because you're stuffing more cholesterol into each particle that you do have. This can make them dysfunctional, whereas lots of small to medium-sized HDL particle gives you greater antioxidant activity, greater anti-inflammatory activity, greater ability to carry cholesterol out of the artery wall, and greater antithrombotic properties. Particle for particle, small and medium HDL particles offer more protection than big overstuffed ones. But if you had big overstuffed HDL boats, your standard HDL-C level would be high, and you'd think you'd be doing good because you'd have a ton of cholesterol packed into each HDL carrier boat. But that doesn't mean your risk of dropping dead from cardiovascular disease is any lower. It's about the particle number again. The more HDL particles you have available to carry cholesterol back from where it doesn't belong and protect you from inflammation and oxidation, the lower your risk. Something we can't measure that's more important than HDL number, which would be reported as HDLP or sometimes ApoAI, is the functionality of the HDL particles. We don't have a way to measure HDL functionality, but it is key for cardiovascular health. ApoAI isn't super useful as a test on its own because it doesn't correlate with HDL particle number the way it always does between ApoB and LDLP. One thing that can give you helpful data, though, is the ApoB to ApoAI ratio. How many ApoB boats that are potentially harmful do you have compared to how many ApoAI boats that are potentially helpful do you have? That's the ratio. There's way more to talk about, but I hope this was helpful to you to learn about today. We might talk about triglycerides in the future. I'll need to learn more about them first because I'm not totally confident in what I think I understand about them yet. Other risk factors for developing atherosclerotic cardiovascular disease are endothelial health. This is huge. Inflammation, the elasticity of your arteries, your immune system function, vitamin K2 levels, and the type of vitamin E you get. It all plays together to create the perfect circumstances for the arterial walls to be damaged and or collect blockages causing plaque. and it usually takes a really long time. But we know that cardiovascular disease is the number one killer by far, so keeping your arteries healthy is absolutely critical if you want to be around and in good health in the future. There are multiple pathways through which you can develop this atherosclerotic cardiovascular disease, which is getting plaques that can clog your arteries and possibly kill you. The lipoprotein pathway, that's what we talked about today. The endothelial pathway has to do with the health of your endothelium. I've been planning to do an episode about that for 2 years now, so maybe now's the time. The endothelium is a very thin layer of cells that line the insides of your arteries, and there are things you can do to promote the health of them and things that damage the health of those cells. Unhealthy endothelial cells are much more likely to let the ApoB lipoproteins through. Then there's an inflammatory pathway, or a state of chronic inflammation that can lead to the deposition of cholesterol in arteries. Also, inflammation plays a role once lipoproteins get through the endothelium and the cholesterol gets deposited and oxidized. Inflammation is supposed to help heal damage the way it does when you get a cut or a burn, but in the case of damaged endothelium and high ApoB particle numbers, it makes things dangerously and sometimes catastrophically worse, and the plaque that forms could rupture. So all of these factors need to be considered when assessing your cardiovascular disease risk. But at least now you know a lot more about the lipoprotein part of it. I repeated myself a lot today, so I hope it's not too annoying. It helps me when I'm learning something new, so I hope it helped you too. Just remember that there are lots of factors that play into your cardiovascular health, but in terms of evaluating your risk from lipoproteins, first of all, there's no bad cholesterol. It's all good. There aren't different types of cholesterol. LDL and HDL are protein particles that transport cholesterol around, not types of cholesterol. Standard lipid panels report your total cholesterol and total cholesterol carried by LDL and by HDL. And knowing your total cholesterol carried by LDL and HDL doesn't really tell you anything about your cardiovascular risk. What really matters is the total number of LDL particles, sometimes called LDLP and sometimes called ApoB, that you have, and your ApoB to ApoAI ratio. So ask for either an ApoB test or an LDLP test along with an Lp(a) test if possible, because that matters a lot too. The greatest risk among many risks of getting cholesterol deposits in your artery walls probably comes from how many LDL particles are floating around in your blood plasma and for how many years you're exposed to those particles. Thank you so much for taking the time to get so smart. The world needs you to protect your arteries so that you have more opportunities to make a difference for the people who depend on you. Next week, we're going to talk about one of my favorite concepts, acting like a librarian, cataloging and collecting and shelving good ideas, which I totally tend to do, and why and how to stop being a librarian and what to do instead. Until then, go talk to someone about what apolipoprotein particles are, or better yet, go get yours measured, and they'll be normal. Thank you so much for tuning into the Health Courage Collective podcast. I am truly honored that you have paid me the enormous compliment of your time and attention. I would be so grateful if you would share this podcast with someone you know and subscribe so you never miss an episode. This podcast is for entertainment and information purposes only. Statements and views on this podcast are not medical advice. This podcast, including Christina Hackett and producers, disclaim responsibility for any possible adverse events by use of information contained herein. If you think you have a medical problem, consult a licensed physician.